Welcome guys, I am Dr. Priyansh Jain, your faculty of Biochemistry at Dr. Tutorials. This session is for the recall of INI-CET 2025 in the June session. There were around 11 questions that is there from Biochemistry. Let's start with the first question. That was from the very common topic, that is electron transport chain. So the question was carbon monoxide and cyanide leads to death because they affects what? Now, when it comes to this question, the options were controversial because we know that carbon monoxide, cyanide, they are going to affect the complex 4 of electron transport chain. Here you can see the table from the notes that the cyanide, carbon monoxide, they are going to affect the complex 4, and the complex 4 is cytochrome oxidase. Now, when we go to the option, there is no option such as called as the cytochrome oxidase. Whereas one similar option was cytochrome C1. Cytochrome C1, if you look at this particular table, cytochrome C1 is a component of complex 3. Cytochrome C1 is a complex 3 component, right? And cyanide, carbon monoxide, they does not stop the complex 3, they stop the complex 4. But because there is no other choice which is near to this, if this was the option, that cytochrome C1 was the option, then we have to go with this, because the other options, they are not related with this, because the other options, the myoglobin, NADH dehydrogenase, that is complex 1, ATPase, they are not related, right? So the only option which is going closest to the answer is going to be the cytochrome C1. But if the options were directly like this, if the option was cytochrome oxidase, definitely that is going to be the answer, right? So these are the important inhibitors that is to be remembered: rotenone, phenobarbital, phenobarbital, they are going to inhibit the complex 1, that is NADHQ oxidoreductase or dehydrogenase. Complex 2, that is succinate Q reductase, that is inhibited by malonate, carboxane, TTFA. Complex 3, cytochrome oxidoreductase, is going to inhibit by BAL, antimycin. And complex 4, which is cytochrome oxidase, is going to be inhibited by cyanide, carbon monoxide, and hydrogen sulfide. Let's move to the next question. Which of the following is the most appropriate genetic test to identify multiple mutation across different genetic sites? If we want to find multiple mutations at the same time, then there are different methods that is there. Now, one of the method that they have said is Sanger sequencing, RFLP, exome sequencing, and FISH. See, FISH is very clear cut. FISH is for the chromosomal studies, to see the microdeletions, to see the trisomies, monosomies, duplication, translocations. We do FISH. We don't do the FISH technique for to see the multiple mutations, right? That is at the DNA level that we can't see in the FISH. So FISH cannot be the answer. Now we are left with Sanger, RFLP, and exome sequencing. Now, when it comes to RFLP, that is basically length polymorphism. Again, if the mutation is such that is going to change the length of the chromosome, the DNA, then yes, we can identify by RFLP. Exome sequencing is perfect to find out multiple mutation at the same time. Sanger sequencing can also identify the mutations, but the point is to find out the multiple mutation at the same time. Among the Sangers and exome sequencing, obviously exome sequencing is the next generation one, so we should go with exome sequencing. So here is the table. When it comes to Sangers, it is not suitable for screening of the multiple genes at the same time. RFLP is limited to specific known sites only, whereas the exome sequencing is best to identify multiple mutation across the different genetic sites. And FISH is for the chromosomal abnormalities. It is not to identify the multiple mutation at the same time. So the best answer, because they have asked the most appropriate genetic test, the most appropriate genetic test is going to be the exome sequencing. A patient with hepatosplenomegaly and cherry red spot at macula, which enzyme deficiency is there? Now, when it comes to cherry red spot, it is seen in many disorders, right? We have seen a long list in the class. And hepatosplenomegaly with cherry red spot, then the options are going to be narrowed down. Now, what are the options they are saying? One is the sphingomyelinase deficiency, that is Niemann-Pick disease. Hexosaminidase A deficiency, that is Tay-Sachs disease. Now, if you see them both are having the cherry red spot. Cherry red spot is seen in both, because the glucose 6-phosphatase deficiency, it is going to be the von Gierke's disease, where we don't have the cherry red spot. So this option has been ruled out. Aryl sulfatase deficiency, it is going to be the metachromatic leukodystrophy. that is again not going to have the cherry red spot. Now, when it comes to the hepatosplenomegaly, sphingomyelinase deficiency, that is Niemann-Pick disease, yes, it will have the cherry red spot with hepatosplenomegaly. In the Tay-Sachs, we don't have. In aryl sulfatase deficiency, the metachromatic leukodystrophy, we might have the cherry red spot. Mostly we don't have, but we might also get sometimes. But that is not going to have the organomegaly. In the glucose 6-phosphatase deficiency, we have hepatosplenomegaly, but we don't have the cherry red spot. So they are asking that the combination of cherry red spot with hepatosplenomegaly, and this combination is going up with the Niemann-Pick disease. In Niemann-Pick disease, that is sphingomyelinase deficiency. Now look at here what we have discussed in the videos. Hepatosplenomegaly, all have hepatosplenomegaly except Fabry. Fabry does not have, Tay-Sachs does not have, and Krabbe does not have the hepatosplenomegaly, and this is where one option has been ruled out. The Tay-Sachs has been ruled out here. Now, when it comes to the Niemann-Pick disease, this is what we have discussed about Niemann-Pick disease. The sphingomyelinase enzyme is going to utilize for sphingomyelin metabolism. If the sphingomyelinase enzyme is not there, the sphingomyelin is going to increase. That is going to accumulate in the liver. That will lead to hepatosplenomegaly. It will lead to staring type of look, because the person will have the vertical gaze paralysis. There is going to be foam seals, zebra bodies will be there, and there is going to be cherry red spot. So cherry red spot with hepatosplenomegaly, the answer is going to be the Niemann-Pick disease. What are the other findings that we have discussed? Zebra bodies, foam sails, vertical gaze paralysis. These are the additional findings that will be there. A 90 kilogram male after a meal, which of the following will be actively causing him weight gain? Now, after a heavy meal, what we are going to have? Tell me that you will make the fat or you will burn the fat after the meal. After meal, definitely will make the fat, right? We will have the fatty acid synthesis. We do the burning of fat, that is beta oxidation, during the time of the fasting. During the time of starvation, we burn the fat. But during the heavy meal, we are going to make the fat. So what they're asking is, what will be actively causing the weight gain? Now first let me show you how the fatty acid synthesis happens and how we do the breakdown. When it comes to the fatty acid synthesis, whatever extra glucose that we are having, we convert into pyruvate. Pyruvate converts into acetyl-CoA in the mitochondria. If you want to make a fatty acid, that is carbon chain with acid, you require acetyl-CoA. And right now the acetyl-CoA is in the mitochondria. So we need to bring out the acetyl-CoA with the help of citrate shuttle. The acetyl-CoA will come out. One of the acetyl-CoA with the help of enzyme acetyl-CoA carboxylase will convert into malonyl-CoA, and then we have the factory, the X-shaped factory, fatty acid synthase complex, and that is going to give us the fatty acid. So basically, during the fatty acid synthesis, what are the things required? We require acetyl-CoA, we require citrate shuttle, we require the acetyl-CoA carboxylase, malonyl-CoA, we require fatty acid synthase complex. Now, if you look at the options, what are the things that is required during fatty acid synthesis? We require malonyl-CoA, we require acetyl-CoA carboxylase, we require the citrate shuttle. We don't require the carnitine shuttle, because this carnitine shuttle is used during the beta oxidation of the fatty acid. The remaining is utilized for the fatty acid synthesis. So the answer is going to be the 1, 2 and 4, the combination of 1, 2 and 4 that is given in the first choice. Now this was straightforward, easy questions. Match the following. They have asked about the various blotting. We have discussed one mnemonic. I will just show you the notes. The snowdrop. This is the mnemonic that we have discussed in the class also. When it comes to snowdrop, southern blotting is to detect any particular DNA. Northern is for RNA and western is for protein. We have also remembered like this. In south we have dosa. Dosa is DNA. North is roti. Roti is so RNA. And west we have the pizza, so proteins. So either snowdrop or like dosa, roti and pizza. So it was a very straightforward, clear-cut question that southern blotting is done for what? Southern blotting is done for DNA. That is given in the option D. Northern blotting is done for RNA. Western blotting is done for protein. And eastern blotting is done for enzymes. So the answer is DCAB, the second choice. Now it was more of a logical question that was there. After how many cycles of PCR would the number of DNA copies be half the amount obtained after 26 cycles? Now, one thing is very clear. See, when we do what is PCR is, from one DNA, if you want to make 2 copies of DNA, you will do the PCR. Then again, if you repeat the cycle from 2, you will get 4 copies. If you repeat the cycle, you will get 8 copies. If you repeat the cycle, you will get 16 copies. Right? With every cycle, the numbers are going to double. Now, for example, this is the first cycle, this is the second cycle, this is the third cycle, this is the fourth cycle. After 4th cycle, you are having 16 copies of the DNA. Half of 16 is going to be 8, and 8 was available in after how much cycles? 3 cycles. So what they're asking is, whatever number you are going to obtain after 26 cycles, half of that will be obtained in which cycle? Obviously, one number back. Because, for example, in the 4th cycle, we are having the 16 copies. If I ask you that half of 16, when you are going to get? In the 4th cycle or the 3rd cycle? Yes, it is going to be the 3rd cycle, 1 cycle back. Because with every cycle, we are doubling. This is a simple logical question that with every cycle, we double the numbers. Right? So they are asking that whatever number you are going to get at this particular stage, let's say at 26th cycle, you are going to get X number. When you are going to get X half, we are going to get at 25th cycle. Right? So this is what they were asking. It was more of a logical mathematical question. So after 26th cycle, whatever is the number, the half of that will be obtained in 25th cycle. In glucose 6-phosphate dehydrogenase deficiency, which of the following pattern is most likely seen? With what will be the level of direct bilirubin, indirect bilirubin, and urobilinogen? Now, when it comes to the G6PD deficiency is an X-linked recessive disorder. It will lead to hemolytic anemia. There is going to be excess amount of hemolysis will happen. Now, to answer this question, we need to understand the bilirubin metabolism. See, normally what happens is, when the RBC breakdown happens, we are going to get the hemoglobin. The hemoglobin further will convert into biliverdin, and that will convert into bilirubin. And that is the unconjugated or indirect bilirubin, the water-insoluble bilirubin. Then this water-insoluble bilirubin, the indirect bilirubin, goes to the liver with the help of albumin. And the liver is going to conjugate it and will make the conjugated bilirubin. Then this conjugated bilirubin, once it is made, this conjugated bilirubin will come in the intestine, and with the help of the gut bacteria, it will convert into urobilinogen. So if there is more hemolysis, there will be more unconjugated bilirubin will be made. So here it is, what is happening is that we are going to make more unconjugated, because the spleen is the one that is doing the hemolysis, right? If there is excess amount of hemolysis, because if the G6PD enzyme is not there, the excess amount of hemolysis will happen. And in any hemolytic anemias, the unconjugated means the indirect bilirubin is going to increase significantly, and that will go all the way to the liver. The liver will process it and will make the conjugated bilirubin, and then conjugated bilirubin will be coming out, and this conjugated bilirubin will be converting into urobilinogen, stercobilinogen, because the unconjugated bilirubin is more, so there is more pressure in the liver to work more, and ultimately the urobilinogen, the stercobilinogen will also be made more. Now, when it comes to the jaundice, we have divided the jaundice into 3 categories: prehepatic, hepatic, post-hepatic causes. And this is a problem in the spleen. So it's a prehepatic cause, and here you can see the table. What happens in the prehepatic? In the prehepatic, the unconjugated bilirubin means the indirect bilirubin is going to increase. In the urine, we don't have the bilirubin will not come, because bilirubin only comes in the liver if it is a direct bilirubin increasing. The water-soluble things can come in the urine, but not the water-insoluble things. So unconjugated bilirubin cannot come in the urine. So in a patient of hemolytic anemia, which is a type of prehepatic jaundice, in the hemolytic anemias, there is going to be the urine bilirubinogen is going to be increased, and unconjugated bilirubin means the indirect bilirubin is going to increase. So here they have asked that what is going to happen with this sequence. The direct bilirubin, the indirect bilirubin, and the urobilinogen. Definitely urobilinogen will be more. The unconjugated bilirubin will be more. The direct bilirubin will be normal or slightly more. Now, if you see the option, the urobilinogen, because the classical finding is increased amount of urobilinogen, increased amount of indirect bilirubin. Now, if you look, even if you were knowing this much of the fact that in in the hemolytic anemias, the RBC breakdown will happen and we are going to increase the unconjugated bilirubin. The indirect bilirubin is going to increase. And if you look at the option, there is only one option saying indirect bilirubin increase. The urobilinogen increase and the direct bilirubin can be normal, can be increased. So the answer is going to be the first one. So the very classical finding in the hemolytic anemias, the prehepatic jaundice, is going to be the increased amount of indirect bilirubin, the unconjugated bilirubin, the water insoluble bilirubin. And to see the urobilinogen in the urine, see what are the tests that we have related to the bilirubin. We have the Vandenberg reaction and the Ehrlich reaction. Vandenberg is a blood test to find out that how much the direct bilirubin, indirect bilirubin, to differentiate them, that how much they are there. And Ehrlich is for to find out the urobilinogen. It is a urine test to find out the urobilinogen. The next question was, the cancer cells are known to consume more glucose than normal cells. What of the following is the best explanation for that? It's a classical question on Warburg hypothesis. See, what they are saying is the cancer cells are consuming more glucose. Why? Normally, when the glucose is metabolized, there are two methods, aerobic and anaerobic. The aerobic is more fuel efficient, that gives more energy, whereas the anaerobic gives very less energy, and that produces the lactic acid. If you remember the anaerobic glycolysis, when you make the lactic acid, we just generate 2 ATPs. If you remember this pathway from our notes, the glucose converts into pyruvate. The pyruvate is having two choice. If it goes into the anaerobic pathway, it will make the lactic acid. And if it goes into the aerobic, it will convert into the acetyl-CoA. The acetyl-CoA will run the Krebs cycle, which generate a lot of energy. Now, when it comes to the cancer cells undergo the glycolysis. Despite presence of oxygen, they make lactic acid. And this is called as Warburg hypothesis. And if you make lactic acid, you are just going to generate 2 ATP. If you compare the pathway, if you have a glucose molecule, and you go into this aerobic side, means from the glucose till pyruvate, acetyl-CoA, Krebs cycle, it is going to give you 32 ATPs. One molecule of glucose will give 32 ATPs. Whereas if we go in this side of the pathway from the glucose, pyruvate, and ultimately lactic acid, we are just going to get 2 ATP. So one glucose molecule can give you 32, can give you 2, depending on which path you are going. And the cancer cells are going towards lactic acid. And if you go towards lactic acid, you will consume a lot glucose to generate ATP. It's not a fuel efficient pathway, right? So they are asking that why the cancer cells are consuming so much of glucose. That is because they are producing the lactic acid despite the presence of oxygen. That is the Warburg hypothesis. It's the Warburg hypothesis. In insulin resistance, which cell has decreased uptake of glucose? See, to take the glucose, we have the glucose transporter, that is GLUT. The GLUT transporter we can divide into two categories, the insulin dependent and insulin independent. The insulin dependent is GLUT 4, 8 and 12. The remaining are the insulin independent. Among them, the GLUT 4 is the most important one. It is found at 3 places: adipose tissue, cardiac muscle, skeletal muscle. So the insulin dependent glucose transporter means the glucose uptake is dependent on insulin in these 3 tissues: adipose tissue, cardiac muscle, skeletal muscle. Skeletal muscle, adipose tissue and the cardiac muscles. Among the given choice, the answer is going to be skeletal muscles, because in the rest of the places we don't require the insulin molecules. To take up the glucose in the kidney, we have the SGLT. In the kidney, we have the SGLT, the sodium dependent glucose transporter 2. In the brain, we are going to have the GLUT 3. Sometimes GLUT 1 also. In the RBC, we have the GLUT 1. So GLUT 1, GLUT 3, SGLT 2, they are not insulin dependent. Whereas in the skeletal muscle, we have the GLUT 4. And the GLUT 4 is going to be the insulin dependent. Here is the table from your notes. The GLUT 4 is going to be the insulin dependent. It is found at 3 places: skeletal muscle, cardiac muscle and adipose tissue. In the nephron, we have the SGLT2. In the neurons, we have the GLUT3, and in the RBC, we have the GLUT1. A patient presents with hepatosplenomegaly and hypoglycemia. On glucagon administration, there is improvement in the blood glucose after a meal, but no improvement after overnight fasting. Liver biopsy shows some abnormally structured glycogen molecules Which most likely enzyme deficiency? See, first question is, it's related to glycogen metabolism. It's a glycogen storage disease. And I told you that whenever there is hypoglycemia related to glycogen storage disease, two disease should come in your mind immediately. One is going to be the von Gierke's disease, and second is the Cody disease. Von Gierke's is due to deficiency of glucose 6-phosphatase. And Cody disease is due to deficiency of debranching enzyme. Now, both are the disease where the glycogen, when we do the glycogenolysis, when we cut the glycogen, these enzymes are required. Now, why we cut the glycogen? It's very simple thing that, see, when we cut the glycogen in the liver, basically we want to make the glucose. We want to make a lot of glucose. We are going to get many molecules of glucose, n number of glucose molecules we are going to get, and this process is called as the glycogenolysis, the breakdown of the glycogen. If there is problem in this pathway, you can't make the glucose, and if you can't make glucose, you will go into hypoglycemia. And these two diseases are very notorious to develop hypoglycemia. Von Gierke will have more severe hypoglycemia compared to Cody disease. Now, because there is no severity mentioned, they have just mentioned hypoglycemia. They have mentioned hepatosplenomegaly. Now, hepatosplenomegaly can be seen in both. Hypoglycemia can be seen in both. Then how to differentiate? One thing they have mentioned is, on the liver biopsy, there is abnormally structured glycogen is there. See, what happens is, in the Cody disease is due to deficiency of debranching enzyme. When you cut the glycogen molecule, you initially will cut with the help of glycogen phosphorylase. You will cut. Then to cut the branching point, you require the debranching enzyme. And if the debranching enzyme is not there, we can't cut the branch. And it will look like this. Just look like this. To cut this small branch, we require the debranching enzyme. And if this debranching enzyme is not there, we cannot cut further the glycogen. And these abnormally short branched glycogens will accumulate in the liver. The moment there is a short branched abnormal glycogen in the liver is accumulated, it is a debranching enzyme deficiency, and that is going towards the Cody disease. So the answer to this question is going to be the deficiency of debranching enzyme, that is Cody disease. If you see the first one, the muscle phosphorylase deficiency, that is the type 5 glycogen storage disease, where the patient is going to have the problem when the patient will do some physical exertion, the patient will have the muscle pain, dark urine. That is the McArdle's disease. That is the muscle phosphorylase deficiency, right? The glucose 6-phosphatase, that was the von Gierke, I told you, but there are hypoglycemia, there is hepatosplenomegaly, but there is no abnormally structured glycogen will be there in this disease. In the glucose 6-phosphatase deficiency, there is going to be hyperuricemia, hyperlipidemia will be there. So that is not given in the choice. So these cannot be the answer. In this given glycine titration curve, which pH the molecule will exist in the zwitterion form? What is the meaning of zwitterion? Zwitterion means a molecule which is having equal amount of positive charge and negative charge at the same time. That is called a zwitterion. And the zwitterion, because the net charge is 0, so they are water insoluble. So they are asking that glycine will be found at which pH it will be found in the zwitterion. The pH where you are going to generate the zwitterion, that is called as the isoelectric pH. So we have to find the isoelectric pH for glycine. Glycine has one amino group, one acidic group. So glycine is having one amino group and one acidic group. So we have to see that what is pK1 and what is pK2. The average of these two will be the isoelectric pH. They have given the 9.6 and 2.3. It's coming out to be 11.9. It's roughly 12. Now the average of these two, the pK1 plus pK2 divided by 2. So here it is 11.9 divided by 2, almost around 6. The closest option is 6. So that is going to be the answer. Right? So this is all from the biochemistry part. And I have deliberately attached the screenshots of the notes for your reference, so you can see that how the question has been framed. And while reading the notes, you can correlate the things and you can have the insight of the examiner, that how the examiner thinks, right? So while reading the notes also, because it's very important, just reading the notes is not going to solve the purpose. We need to have that insight. We need to have that attitude that if you are examiner, how you are going to frame the question from those particular topics, right? So that is going to help you, that is going to build that character in you. You will be start thinking like your examiner, and once we start doing that, the things will not look new in the exam. Because many of the times we feel ki I have seen this in the notes, oh I have seen here there, but we are not able to recollect the dots very easily in the exam because of many reasons. One of the heat of the exam, plus we were just reading the notes in the monotonous way. So whenever you complete a topic, take a pause for a couple of minutes and think like an examiner, that if you are examiner, how you will make a question from glycogen storage disease. I can connect from here to here, I can twist the question from here to there, and likewise we will develop the cross synapse, the multi-directional synapse in our brain, so nothing will look new in the exam, right? Thank you guys.